I will be joined in this session by three distinguished speakers, namely Dr. Nahid Makki, Dr. Emad Alqedra, and last but not least, Dr. Asmaa Rimawi. The first presentation is titled, The First National Survey of Diabetic Retinopathy in Palestine, a cross-sectional study, and is presented by our colleague, Dr. Nahid Makki. Nahid Makki is a Palestinian pediatrician and holds a PhD degree in public health and epidemiology. She worked in the fields of pediatrics, epidemiology, and teaching in important Palestinian institutions. These institutions include Birzeit University, St. John Eye Hospital Group, Makki Hospital, Augusta Victoria Hospital, and Arab American University of Palestine. Her research experience is in the fields of women's health, adolescent health, diabetes, and ophthalmology. Nahid, please start your presentation.
My name is Nahid Makki. I work as a research consultant at St. John Eye Hospital Group in Palestine. St. John Eye Hospital Group is the only charitable provider of expert eye care and the only eye research center in Palestine. This group is composed of 5 facilities in different areas of Palestine to reach all Palestinians. So these facilities are 3 hospitals in Jerusalem, Hebron, in the southern area of the West Bank, Gaza, 1 big center in Nabta in the northern area of the West Bank, and 1 primary healthcare clinic in the Old City in Jerusalem. St. John Eye Hospital Group conducted this survey in partnership with the Fred Hollows Foundation, CBM MOFA, London School of Hygiene and Tropical Medicine, and Palestinian Central Bureau of Statistics. DR survey was 1 component in a larger survey that included 2 other components. These components were the Second Rapid Assessment of Avoidable Blindness survey and the Disability survey. My presentation will be mainly about the diabetic retinopathy component. In the first rapid assessment of avoidable blindness that was conducted in Palestine in 2008, the prevalence of blindness was 3.4%. The prevalence of severe visual impairment was 2.6%. The prevalence of moderate visual impairment was 10.7%. More than 80% of blindness, severe visual impairment, and moderate visual impairment were avoidable. Avoidable means either treatable or preventable. Treatable causes include cataract, refractive error, and aphakia. Preventable causes include diabetic retinopathy, glaucoma, cataract surgical complications, and corneal opacity. So in that survey, cataract was the dominant cause of blindness. It caused around half of the cases of blindness. Corneal scar was the second cause of blindness. It caused 14% of the cases of blindness. Diabetic retinopathy was the third cause of blindness, and it caused 8% of the cases of blindness. So in Palestine, the prevalence of diabetes mellitus among those aged 25 to 64 years is predicted to reach 23.4% in 2030. This rate is one of the highest in the region. Diabetic retinopathy research in Palestine was clinic-based population. There were no national surveys or community-based studies. So the prevalence of diabetic retinopathy in one study that was conducted in Ramallah clinics among diabetes patients in 2012 was 33%. 1/3 of diabetes patients in that survey had never had their eyes examined. So the aims of the survey that had 3 components and that was conducted by St. John Eye Hospital group were Estimate the prevalence and main causes of blindness and visual impairment in the rapid assessment of avoidable blindness component. Estimate the prevalence and grade of diabetic retinopathy among diabetes participants in the diabetic retinopathy component, and estimate the prevalence of different types of disabilities in the disabilities component. As I said earlier, my talk will be mainly about the diabetic retinopathy component. As for the methodology of the survey, we used a standardized methodology that was developed by London School of Hygiene and Tropical Medicine. Dr. Ayla Maktagar from the school calculated the sample size, selected the sample using GRAB6 software, and trained the teams. Dr. Maktagar, she could not travel to Gaza, so I and one of the West Bank teams traveled to Gaza and trained the team there. So the sample was a nationally representative cross-sectional population-based survey of people aged 50 years and older. So the sampling frame was a list of enumeration areas, which are the smallest population units recorded in the 2017 Palestinian census. PCBS provided us with these areas and also with the necessary maps for the survey. So the survey area was the West Bank and Gaza, Jerusalem areas inside the wall were excluded. The Palestinians didn't have the required data about these areas because they could not access these areas. So study clusters were selected using a probability proportional to size approach. The participants were 50 years and above. This age group was chosen for the survey because 81% of all people who were blind or had moderate to severe vision impairment in the world were aged 50 years and above. So the prevalence of visual impairment in this age group was the highest. Including younger age group will increase the sample size a lot, as the prevalence in younger age groups is small, and this will be done at a small added value. So the survey was conducted in the participants' place of living. Visual acuity was measured using peak acuity mobile phone application. Lens exam was done by an ophthalmologist using a portable slit lamp. Retinal exam also was done by the same ophthalmologist using indirect ophthalmoscope. Now, diabetes patients were diagnosed either as having diabetes if they had already been diagnosed as diabetics prior to the survey, or if they had a random blood sugar, which was measured for all participants higher than 200 milligrams per deciliter. So fieldwork was conducted between July 2018 and April 2019. The sample size was calculated at 4,224 participants. There were 69 locations in the West Bank and 52 locations in Gaza. The number of males in the sample was 1,801, and the number of females was 2,047. The total non-response rate defined as refusal or non-available participants or participants not capable of communication was 9.1%, which was acceptable since the non-response rate in the sample calculation was set as at 10%. So the prevalence of blindness was 2.8%. The prevalence of severe visual impairment was 1.6%. The prevalence of moderate visual impairment was 11.3%. and the prevalence of early visual impairment was 12.4%. So the prevalence of any degree of vision impairment was 28.1%. So the prevalence of the blindness was higher among women than among men, and it was higher among Gaza than in the West Bank. So the number between the brackets is the extrapolated sample results to population. So the total number of Palestinians aged 50 years and above with any degree of vision impairment in the survey was around 133,000 cases. These constitute around 1/4 of Palestinians in this age group. Now this pie shows the cause of blindness in the sample. As you can see, the main cause of blindness was cataract, which caused 38% of the cases of blindness. The second cause was diabetic retinopathy, which caused 24% of blindness. In the West Bank, the main cause of blindness was cataract, which caused around half of the cases of blindness. In Gaza, the main cause of blindness was diabetic retinopathy, which caused around 1/3 of cases of blindness. As for diabetes prevalence in the sample was 33.2%. Diabetes prevalence in Gaza was higher than diabetes prevalence in the West Bank. Diabetes participants, as expected, had higher vision impairment than non-diabetes participants. In Gaza, the principal cause of blindness was diabetic retinopathy, as I mentioned earlier, and the principal cause of blindness in the West Bank was untreated cataract. More than 40% of people with diabetes either had never had an eye checkup or had not been checked more than 2 years prior to the survey. 48% of participants with diabetes had diabetic retinopathy and or maculopathy. Any retinopathy and or maculopathy was higher among older age group. In conclusion, almost all degrees of vision impairment were avoidable. Diabetes prevalence and diabetic retinopathy were very high. So earlier detection and proper management is a priority. It's well documented that early diagnosis and management of diabetes and diabetic retinopathy are very important to prevent complications, loss of sight, and to maintain a good quality of life for diabetes patients. Referral and pre-referral networks should also be built between different healthcare sectors and specialized eye centers. Thank you.
Thank you very much, Dr. Nahid, for this interesting and nice presentation. The floor is open now for questions. So anybody who would like to ask, they may raise their hands or send a question in chat. A question, how do you compare the current study that you presented with the study that you did in Ramallah Governorate in 2012? I think the prevalence of diabetic retinopathy in the Ramallah study was about 37%. So any thoughts about that, Nahid, please? Nahid, can you hear me? Nahid, you are muted. Can you open the mute?
Again, could you repeat the question?
Okay, I'm asking how do you compare the current study that you presented?
No,
I can't hear you well, Dr. Nahid. Dr. Nahid, can you repeat because I cannot hear you well?
From my
Okay, it seems that there is a technical issue with.
I don't know what the problem is.
I think we can hear you now. You can go ahead. Sorry, the voice is lost with Dr. Nahid, so maybe we can leave this to the end of the session. And we can now ask Dr. Emad Alqedra. The second presentation is titled Oral Health Problems Among Type 2 Diabetic Patients Attending UNRWA Health Centers in the Gaza Governorate, and will be presented by Dr. Emad Alqedra. Dr. Emad Alqedra is a dental surgeon in the Health Department, Gaza Field, UNRWA, since 2012. He's a former dentist in the Ministry of Health, Gaza Strip, from 2005 to 2011. He has an MPH from Al-Quds University and BDS from Sindh, Pakistan University. His research focus for many years was on oral health, health services, and management. He published in many high-impact journals, and he was invited to present his research work in many conferences and meetings. Dr. Emad, the floor is yours, and we'll postpone the questions to the end of the session. Please go ahead.
Good evening. I am Dr. Emad Alqedra, dental surgeon from UNRWA Gaza Field. I am going to present my study titled Oral Health Problems Among Type 2 Diabetic Patients Attending UNRWA Health Centers in Gaza Governorate. First of all, why we are studying oral health of diabetic patients. Oral health is an essential component of general health, an important determinant factor of life. So oral health and general health are related to each other and should be integrated rather than separated from each other. Also, treatment of oral health problems places a considerable economic burden on individuals, communities, and countries. Major chronic diseases such as diabetes mellitus share common risk factors with oral disease, for example, diet, hygiene, smoking, and alcohol. Furthermore, periodontal infection and diabetes mellitus have a two-way relationship. So controlling of diabetes mellitus will improve periodontal health, while maintaining a good periodontal health will improve the control status of diabetes mellitus. By the way, periodontal diseases is the sixth most common complication of diabetes mellitus, and diabetes mellitus is the strongest risk factors of periodontal infection. Despite the magnitude of oral diseases and their systemic linkage with other diseases, oral health is commonly neglected, and studies concerning oral health care of the population are very rare in Palestine. The aim of this study is to highlight oral health of diabetic patients in order to know their oral health problems and their oral health needs. In addition to that, answer some questions like, what is the dental and periodontal health status of diabetic patients? And is there an association between dental caries and periodontal diseases and socio-demographic characteristics, diabetic duration, and hemoglobin A1C level? To achieve the aim of the study, we used an analytical cross-sectional design. During the time of collecting data, 2017, the total number of type 2 diabetic patients was about 40,000 patients. Participants from 35 to 65 years old attending UNRWA Health Center were included. Pregnant ladies excluded to avoid the oral consequences of pregnancy, and participants above 65 years old also excluded because they have different oral health assessment forms. A proportional systemic random sampling method used. So Gaza Strip was divided into 5 geographic areas. One health center from each area was selected randomly. The sample size was calculated to be 381 participants. The sample in each health center was calculated according to the number of type 2 diabetic patients in each health center. For collecting data, WHO Basic Methods 5th edition 2013 is used, including interview questionnaire, with oral health assessment form for adults. Now heading to results. The mean age of participant was 54.6 years. Approximately quarter of participants were of age group less than 50 years. 59.9% of participants were female. Majority of participants, about 91%, have formal schooling. Despite the majority of participants are less than 60 years old, only 19.7% of participants are working. The mean of monthly income of participants was 959.5 new Israeli shekel. 87.2% of participants are under the poverty line. Most of participants are refugees living in poor and crowded refugee camps. This explains why majority of them were not working and do not have sustainable sources of income. Also, this is in line with current condition in Gaza Strip due to the siege, unemployment, and low wages. According to the annual report of UNRWA Health Department 2016, the number of patients with NCD is increasing by approximately 5% per year, and the number of diabetic patients is almost doubled last 10 years. Results showing that participants with type 2 DM since less than 5 years were 33%, and those with type 2 DM since 5 to 9 years were 26.8%, while 22.2% of them from 10 to 14 years, and 18% 15 years and more. Now, depending on UNRWA categorization of participants according to their hemoglobin A1C level, participants were divided into two major groups: controlled group equal or less than 7%, and uncontrolled group more than 7%. The result showed that 21.4% of participants were controlled. This result is almost running with UNRWA reports, where the percentage of controlled diabetic participant was 30% in 2016 and 27% in the year 2017. The difference between the result of the study and UNRWA reports is attributed to the limited age group of my study. The distribution of participants according to their frequency of teeth cleaning. This confirmed the lack of awareness for oral maintenance, lack of knowledge about oral complication of diabetes mellitus, and absence of appropriate health education. Generally, people need at least 2 times brushing a day. Only about 16% brush their teeth twice or more a day, and more than 1/3 of participants never brush their teeth. Now, the MFT index. The mean number of sound tooth is 12.2. The mean number of decayed teeth is 6.1, while the mean number of missed teeth is 7.2 due to caries and 3.3 due to another reason but not from caries, whereas the mean number of filled teeth appear to be very low, 1.6. These findings suggest that oral health care in Gaza consists of radical treatment in terms of tooth extraction and reflects the lack of interest of participants in the treatment of teeth decay. The MF index for all participants is 18.6, which considered extraordinarily high. The distribution of the study participants according to their DMFT index, it clearly shows the positive relationship between age and DMF index, since the index increases with increased age. People with diabetes are more likely to have periodontal disease than people without diabetes. The mean number of teeth showing absence of gingival bleeding is 9.97, while the mean number of teeth showing the presence of gingival bleeding was 9.91. In addition to that, the mean number of teeth showing absence of bucket 7.15, while the mean number of teeth showing buckets of 4 to 5 millimeter 7.84. The mean number of teeth showing bucket of 6 millimeter or more 4.96. Only 16.4% of participants have no gingival bleeding, and 9 participants representing 2.4% have no periodontal buckets. This is confirmed by the result of urgency need, which showed that more than 70% of participants need scaling. Now, inferential statistics. First of all, Relationships between DMF index and participant characteristics. DMF index value is significantly associated with age, educational level, employment status, but not with gender and monthly income of participants. DMF index is statistically significant associated with age. With the increase in age, there is an upward trend in DMF index. No statistically significant association between DMF index and gender. Generally, females showing higher DMF index than males because they tend to fill their decayed teeth. But results showing DMF index of male 19.1 was higher than DMF index of female 18.3, where males tend to extract their decayed teeth more than female. Obvious statistically significant association between educational level and DMF index occur. DMF index is inversely proportional to the educational level. Another statistically significant association between DMF index with employment status, while there was no statistically significant association between DMF index and income of participants. This attributed to the big gap between the participant above and participant under the poverty line. There is statistically significant association occurs between DMF index value and diabetic duration, increasing DMF index with increasing diabetic duration. A clear and statistically significant association occurs between DMF index value and hemoglobin A1C level. The result reveals that the poor glycemic control and the early onset of diabetes mellitus may increase the risk of dental caries. A clear and statistically significant association occurs between DMF index value and the frequency of teeth cleaning or brushing. The relationship is inverse. The increase in the frequency of teeth brushing decreases the DMF index value. Now, relationship between gingival bleeding and participant characteristics. Results showed no association between gingival bleeding and also socio-demographic characteristics of participants, except gingival bleeding was statistically significant with gender. There is no statistically significant association between gingival bleeding and diabetic duration and control status of diabetes mellitus. A statistically significant association between gingival bleeding and the frequency of teeth cleaning or brushing occur. These results are in disagreement with the most available studies. The main reason behind this result could be increased number of teeth not present for gingival examination. The mean number of teeth not present for gingival test is 9.14, which is very high. Contrary to expectation, there is neither a clear relationship nor statistically significant association between periodontal pockets and any participant characteristics. The results are in disagreement with the most available study. The main reason behind this result could be increased number of teeth not present for pocket measurement. The mean was 19.13, which also very high. Moreover, the early onset of the chronic periodontitis among most of the participants, I mean diabetes mellitus here, worsened the periodontal status rather than causing the periodontal problem. Strengths of that study: it is the first time to study oral health of diabetic patients. The study is analytical research. It generates new knowledge about concepts and identify relationship between many variables: oral health, socio-demographic, and diabetic characteristics. The main weakness point of the study is the absence of the qualitative part. The qualitative approach is the best way to identify main causes of low oral health awareness and a proper way of enhancing oral health awareness among different populations. The study concluded that the patient with type 2 diabetes mellitus have many oral health problems like high incidence of dental caries and periodontal disease, high tooth loss rate, and low teeth replacement rate. And most of patients are unaware of oral implication of diabetes. Intervention urgency needs, showing that no treatment was needed for 8.4% of participants, while 13.8% needed preventive or routine treatment. Combat treatment, including scanning, was needed for 70.1% of participants, and immediate treatment, urgent treatment due to pain or infection, was needed for 7.7% of participants. These results correspond to the oral problems of participants, where most of them suffering from caries, bleeding gums, and periodontal pockets. A new UNRWA strategy for oral health must be devised for NCD patients based on increasing awareness of diabetic patients and healthcare provider about oral implication of diabetes mellitus. Oral health assessment should be performed once yearly for all NCD patients on WHO tool basis and preferred to be performed in the day of annual general assessment. Patients should be given an immediate appointment for intervention in case of required and a close follow-up. NCD patients should be given a priority in appointment system for oral health curative procedure. Periodic scanning for diabetic patients at least once yearly. Study recommended that more similar study should be conducted at national level among school-based students, pregnant women, and the preconception women. At the end, I would like to thank all of you for your time and see you in discussion.
Thank you very much, Dr. Emad, for this novel and important study. And of course, the floor is now opened for questions. While the participants warm up, I have a question for you. The question is, what are the main obstacles for improving oral health among type 2 diabetes patients in the Gaza Strip? And if you can also allude to the role of UNRWA compared to the role of government as health providers when you answer this question. Thank you very much. You need to open the mute, Dr. Emad. Please open your microphone, it's muted.
Okay, thank you for you, Dr. Abdullatif, and thank you for the question. First of all, I would like to thank you to give me this opportunity to represent my study here. If I got the question, UNRWA providing oral health services for about 90% of Palestinians refugees in Gaza Strip through 22 oral health clinics. Among them, there is 2 clinics have no dental unit. I want to tell you that we have in 2018, at the time of the study, about 40,000 diabetic patients attending UNRWA Health Center. For them, they have integrated services, including oral health. We are doing at least once oral health assessment yearly. During this assessment, we give oral health education for the patients, educate them how to brush their teeth, educate them about the oral consequences of the oral health of diabetic in their oral health, and if they need any dental intervention, we give them immediate appointment for intervention. For example, if the patient needs scanning or extraction or filling, we give him or her an immediate appointment, available appointment to start immediate dental intervention. Also, all diabetic patients attend at the beginning of diagnosis of diabetic patient, short session about health education, about nutrition, about oral health, and directed to oral health assessment every year. I have no idea about the procedure of oral health assessment in government. This is the answer of the question, if I got it right.
Yes, thank you. But as you know, there are more than one health provider in Gaza, and I think all the efforts should be coordinated together to tackle this very important issue. Thank you very much.
Yes.
We have a question from Maysa Kasabri. Please go ahead and ask your question.
Good evening, everybody, and thank you for your presentation, Doctor. What impressed me in your presentation that you mentioned that 36% of the population of diabetic people who are not aware of making a brushing of teeth at all. And imagine the numbers that you said once a week, once a month. If you added to them that you are saying that nearly more than 1/3 of the population are not well aware about the importance of brushing the teeth. If I said there is an economic crisis, you mentioned no significance between the monthly income and the periodontal and oral health problems. I think this is a pressing call to roll out very public campaigns in relation to the importance of brushing teeth starting from the school age. Because I feel this is a serious problem that you are talking only now about the diabetic person. So imagine about the whole population who are.
Okay, did you get the question, Dr. Emad?
The sound is not clear. Could you repeat the question or write it in the chat?
It's not a question, it is a type of analysis of your presentation. Because you mentioned numbers and I was giving an image about the seriousness of the problem, about the oral awareness among the population. You are talking about the diabetic. Imagine about the healthy people, how much the problem is large. Thank you.
Thank you. So thank you for your comment. Do you have any response, Dr. Emad? Do you want to add anything?
Yes, I thank you for her comments. That will be. I'm really shocked from the result as here. It is not an economic problem. It is an health education problem. Most of patients, they are not aware about the importance of brushing teeth twice a day, especially if they have diabetes mellitus, because they are unaware of the oral health consequences or implication of diabetic patient. This needs time to be managed, and in UNRWA we start giving short health education session for each newly diagnostic diabetic patient about oral health, proper way of brushing their teeth, about the yearly oral health assessment, and I think after sometimes we will get better result.
Thank you very much. We have another question from Dr. Marilyn Barcelon. She says,
yeah,
thank you for
before the question. Can you hear me?
Yes, I can hear you well.
I can answer your question after this.
Yeah, after we finish with Dr. Emad, inshallah. So Dr. Marilyn Barcelon says, thank you for sharing your study, Dr. Emad. It is true that many of us physicians lack emphasis and awareness about the oral complications of diabetes mellitus. You provided many insights and your relevant recommendations too in your presentation. So this is a comment from Dr. Marilyn Barcelon. Okay, so and we have some other comments on this. Now, if we can go back to the questions for Dr. Nahed, because it seems that now she has a clear sound. Dr. Nahed, there were two questions for you, one from me and one from Dr. Iman Wahed. Let's start with the question from Dr. Iman Wahed. He asked the following: how did the prevalence change with age, 50 to 60, 60 to 70, etc.? And also, how did it change by sex?
So is it the prevalence study or diabetic retinopathy?
I think diabetic retinopathy.
I can answer to both. So with age, so it's higher among older people, and it makes sense because with most probably they have longer duration of diabetes, when they are older. So it increased with age, and it was higher among females than among males, and in Gaza than the West Bank.
Okay, thank you. The other question.
And I would like to add something Please
go ahead.
and it's, I mean, it's obvious that all I mean, care aspects of diabetics are lacking. You know, I showed in my presentation that many diabetics, they did not do their eye exam. So I think it's in the same stream. They didn't brush their teeth and they didn't go for eye exams.
Thank you, Dr. Nahed. I think we lost the sound again with Dr. Nahed. So now we'll go for our third presentation. The third presentation is titled The Implementation and Pilot Outcomes of a Community Health Worker Type 2 Diabetes Program in the West Bank Refugee Camp, a retrospective cohort study, and it will be presented by Dr. Asmaa Rimawi. Dr. Asmaa Rimawi is an emergency medicine resident physician. She graduated from Harvard Medical School in 2021 with a medical degree and a master's in public health. She received her bachelor's degree from Harvard College in Middle Eastern Studies, followed by a master's from the University of Cambridge. She has worked with Juzur for health and social development, the Birzeit University's Rights to Education campaign, and served as the director at the Health for Palestine for 2 years, managing diabetic testing and programming. She currently serves as the director for Harvard Palestine's Health Initiative and as a Palestinian American Research Center Park Research Fellow. Can we have the presentation of Dr. Asmaa now?
Hi everyone, my name is Asmaa Rimawi. I'm a recent MD and PhD graduate from Harvard Medical School, and I'm currently a first-year emergency medicine resident physician. I'll be presenting the study titled Pilot Outcomes of a Community Health Worker Type 2 Diabetes Program in West Bank Refugee Camps, a retrospective cohort study. Okay, a necessary disclosure before I jump into the presentation is that I did serve as the Director of Data Management and Analysis for Health for Palestine. Health for Palestine is the organization whose work will be discussed in the presentation. However, I have never received any financial compensation for said work. Okay. The aim of this study was to assess the efficacy of the diabetes arm of a community health worker program based in Aida and Al-Azza refugee camps in Bethlehem. The community health worker program called Health for Palestine was started in 2017. 10 community health workers from Aida and Azza camps were hired and trained and assigned 114 patients living within the camps. 47 of those patients were diabetic. And for about 1 year, the assigned community health workers visited those diabetic patients in their homes to assess their blood sugar, assist with medication adherence, as well as accompany them to their medical appointments. This study aimed to assess the efficacy of that intervention, specifically the intervention being a community health worker assignment to a diabetic patient in Aida or Gaza refugee camps. And the hypothesis was that patients assigned a community health worker would see greater improvement in their diabetes when compared to patients without community health worker assignment. There are so many ways to measure diabetes progress. However, for the sake of simplicity, we chose to use hemoglobin A1C as a way to assess diabetes progress. Hemoglobin A1C is a blood marker that cycles every 3 months. It's a continuous value, and a higher number indicates worsening diabetes. And so our final research question is the one you see on the screen. Did patients with community health worker assignment see greater diabetes improvement as indicated by a declining A1C value when compared to similar patients without community health worker assignment within the context of these 2 refugee camps in Bethlehem? Okay. So to test this hypothesis, we decided that a retrospective cohort study would be best. Again, the intervention being assessed is the community health worker assignment, and we decided to use matching to create our control group. And we pulled our controls for the match process from the diabetic patient pool receiving care within the UNRWA Bethlehem clinic. By definition, all patients receiving care from this clinic are refugees, most likely living within Aida or Gaza camp, but also potentially living within Bethlehem proper or other refugee camps. As for the 47 diabetic patients I mentioned earlier who were enrolled in the community health worker program at the start of the study, 30 met the eligibility criteria for the study, of which there were 4. First, baseline hemoglobin A1C greater than 6.4. Anything less than 6.4, we don't really want to push further down from a medical standpoint. So these patients who had a baseline A1C of less than 6.4 were excluded. 2, they had to have one A1C no earlier than 5 months prior to the first visit recorded by the community health workers, and this served as the baseline A1C. 3, at least two hemoglobin A1Cs at least 6 months apart during the duration of the program, so that there was time for the intervention to have an effect. And then 4th, and finally, the patients had to be receiving diabetic care solely within UNRWA Bethlehem Clinic. A little bit more on the matching process. As mentioned at the start, we wanted to compare our patients to patients who hadn't received community health worker assignment. Via coordination with UNRWA, we did this by pulling the medical records of all diabetic patients receiving care at the UNRWA Bethlehem Clinic within the time frame matching that of the intervention. So that was March 2018 to November 2019. And we matched every patient in the community health worker group to 3 patients from the UNRWA clinic. We used a series of if-then statements to match by the following 4 criteria: baseline A1C, plus or minus 0.2, so very, very small window, age, plus or minus 3 years, gender, and then follow-up time. And that left us with 90 controls, because 3 to 1, and our 30 community health worker patients. So 2 important things. First, there's no reason why we did a 3 to 1 match other than to increase our final, N. And then second, in order to decrease the inter-assay variable between A1C testing and to streamline our data process, we decided to also use that same UNRWA database that we pulled the controls from to also pull all the A1Cs on our non-control patients. So all of the A1Cs and all of the demographic information analyzed in the study came from one database, the UNRWA database, and we'll talk about this a little bit more later. Okay, to compare the 2 groups, we created a multivariable regression model with robust standard errors. Clinical knowledge was used to select the covariates included in the model beyond the matching process. Specifically, the factors that we thought may confound the results to some degree were smoking, hypertension, physical activity, history of stroke, and history of myocardial infarction. So those were the covariates or confounders we included. We made the outcome variable change in A1C to ensure independence of observation. So the outcome was, the difference between the follow-up A1C and the baseline A1C. And we did end up with 2 models, one with outliers and one without outliers. And we did use a Bonferroni correction since we have 2 models. Okay, so the first part of our results, this is our table 1 more or less. The first 4 highlighted rows, or the 4 highlighted rows, are the factors we matched on, and we were happy to see that we had no issues with the match clinically or statistically. The other baseline characteristics were also more or less the same, with the exception of 2 things: smoking and physical activity. The intervention group smoked more, but also were more physically active. However, we didn't dwell on this, and we can discuss why later. More results of our analysis. The outlier analysis was not any different in any way from the non-outlier analysis that, in a clinically or statistically significant way. So we won't emphasize that, and I don't even show it here. What is shown here are the unadjusted results, as well as the fully adjusted model with all patients, including the outliers. And again, the pre-specified covariates that we included in the fully adjusted model were history of myocardial infarction, history of stroke, physical activity, smoking status, and hypertension status. And the results show that those patients assigned a community health worker saw a greater decline in A1C by 1.4 points compared to patients not assigned a community health worker, with a p-value significant at less than 0.001. To clarify what this 1.4 point change means, the baseline A1C of both groups was 8.6, and the average A1C upon follow-up in the control group was 0.3. with a non-significant p-value of 0.71. So essentially no change in A1C over a year in the non-community health worker program. Their A1C didn't really go up or down in a clinically or statistically significant way. And so in the intervention group, you can think of the average follow-up A1C being 7.2 compared to the baseline 8.6. So it's not a 1.4% change in the overall A1C. It's a 1.4 point greater decline in average A1C of the intervention group compared to the control group. And just another way to show these results, At baseline, the same percentage of patients in the community health worker group and in the control group had an A1C that was under 8. And that was the case because we matched on baseline A1C, so that's what we expected. After follow-up among the intervention group, 76.7% had an A1C less than 8, compared to 45.6% of the 90 patients without community health worker care. And that was statistically significant using Fisher's exact, with a p-value of 0.003. So our takeaways, as well as our limitations and some other things we wanted to discuss, are on the slide. But the takeaway is that because of the community health worker intervention, patients who would have otherwise seen no change in their A1C value over time have now seen a 1.4 point decline in their A1C over a duration of a year. A 1 point reduction in A1C is associated with a 37% complication reduction rate for diabetic patients and a reduction in mortality by 21% over 10 years. So a 1.4 point drop is pretty good. And the results led us to believe that the community health worker intervention in the camps is a feasible and effective model for improving diabetes control in a setting of persistent direct violence and military occupation. And this is absolutely no different than what any of the other studies show with regard to community health workers. What's unique about this study is that it's among the first in Palestine. It's not the first. The Palestine Medical Relief Society conducted a study in 2003 showing similar promise of their community health worker program, but there have been no follow-up studies since then. And that study was not in a refugee camp setting. And in fact, there are very, very few community health worker program studies in refugee camp settings. So that's what makes this a little bit more unique. However, in these last few minutes, there are some things that we should discuss. I said that because of the community health worker intervention, we saw these results. Obviously, this is an observational study, and we attempted to adjust for confounders, and we matched, but there is potential that there were confounders we failed to include. And then another limitation is that we only had one follow-up A1C, and this should always, raise concerns. Ideally, we would have had more than one follow-up A1C. However, we found on average that patients within the UNRWA system, the time between 2 A1C tests is around 16 months. So more than one follow-up A1C for a retrospective study within our time frame was not possible because it doesn't exist in the data. And then finally, our sample size is really small, with our intervention group having only 30 patients. And this is less problematic statistically because of all of the adjustments we made, and more problematic in attempting to understand how scalable the intervention is. The question being, will efficacy decrease as the patient size increases? However, there is a much bigger issue that we recognize in conducting this analysis, and I really wanted to take a minute to discuss it, and that's the issue of data accessibility and sovereignty. So as I mentioned earlier, we decided to pull data, including A1C values and controls, and intervention patients from the UNRWA records, and that was in no way or form the original plan. Originally, the community health workers had been documenting the A1C values from their patients that the patients were reporting back to them. However, the rate of error that we saw in the A1C values that patients were telling their community health workers were massive. So I've created this table that you can see on the right hand of the slide. This table is an example of what the A1C values looked like in the community health worker records. They were often rounded by the patient or the community health workers. The dates were highly inaccurate, so patients would say, I think I had an A1C, during Ramadan, and I think it was this number. And so we realized we couldn't use the community health workers reliably, their records, reliably as a source of A1C values. So we decided to collect data from a patient perspective, and that we would go with patients to clinics to collect their medical records. And I was in Palestine for this. I was staying in Aida camp, and I have to say it was almost an impossible task. We found that any single patient can visit up to 4 facilities to get their A1C, and every facility had different identification parameters that they used to pull patient records. And even if the patient had those parameters, we'd often find empty files. So this is, not a surprise to anyone who recognizes the fragmented nature of the Palestinian healthcare system and the impacts of a lack of a coordinated medical record system. But to give you an example, for those who are less familiar, if a patient had an A1C at UNRWA and a second A1C at the Ministry of Health, UNRWA needs the ID number that is on the refugee card that patients are given, whereas the Ministry of Health needs the insurance card information. So it's two completely different sets of information. And not all patients know where that information is, but we did get all of that information for patients. We took the time to do that. However, we presented those ID numbers, what we needed. It took 1 year to get those records from UNRWA, 13 months exactly to get through the red tape of accessing that data. Nonstop communication with their review board, but it took 13 months. And the Ministry of Health in Bethlehem had way less red tape. We were able to coordinate with them to make a data agreement with Harvard within 2 weeks, but they use a paper system. And so extracting data was incredibly difficult and inefficient. Incredibly helpful, but just super difficult to get that data, to get those paper records. And it made us realize how little is being systematically collected from a medical and public health standpoint on refugees, and how little patients have control over their medical information. So that was not an intended outcome of the study. It was a massive barrier that extended the analysis time from 21 days, which is the time I set aside for my master's for this project, and turned it into a data collection and analysis process that took 15 months or so. And it's something we need to tackle in our follow-up studies and think about for our refugee population. So as you can imagine, that took a lot of work, 15 months of a lot of work, and there are many folks to thank, all of whom are on the slide. And thank you all for listening. I look forward to discussing with you all.
Okay. Thank you very much. Thank you, Dr. Asmaa, for this brilliant presentation. Actually, many of us are familiar with the fieldwork issues and obstacles, especially the data accessibility related issues. Thank you for outlining that. It seems that Dr. Asmaa is not with us right now, but actually Dr. Bram Wispelwey, her colleague and co-author of the abstract, is here for you to answer any questions that you may have. So until you warm up and prepare your questions, I think Dr. Naveen Abulmele has a question for Dr. Emad. Dr. Naveen, can you please go ahead with your question?
Yes, thank you. And I would like to say thank you for all presenters. They're raising a very important issue related to diabetes and diabetes complications. For Dr. Emad, your results are really very important, and for me, they were very alarming. But my question is, now you started, you studied the patients with diabetes, and we know that we have an issue with oral health in the Palestinian community in general. So how much, well, I think it's a very tricky question, but it's just, you can estimate how much of this is due to diabetes and how much of these oral problems already exist. Because we don't want to say that we're marginalizing this. Maybe we need to start the intervention way before, as Maisa has explained earlier. We know oral health is a marginalized issue in the public health, but how much of this is due to diabetes? Do we have this information, or do you have an idea about this information? It might be an estimate, but just to have an idea, because the results you have presented is really, really alarming. I also have a question, since I'm using this opportunity, to Dr. Asmaa or Dr. Bram. It's very interesting study, but why did you start with this such a small number for the intervention, knowing that you're conducting intervention? We have lots of diabetic patients, lots of people are available, participation rate was good. So why did you start with such a small number? And this is the first question. The second one, why you didn't check the records before you start the study? Not to go afterwards. Usually we start with the already existing information just to have an idea, to have an assessment, and then we can go backward and move forward and build on what is missing from available information. We know that the UNRWA has established an electronic system, so I was surprised that you couldn't retrieve information for individual patients from electronic system. So lots of questions for you, Dr. Bram, but also I would like to hear Dr. Emad. Thank you.
So let's start with Dr. Emad. Please open the mute, Dr. Emad. You are still muted. Please open your microphone.
Thank you. Thank you for all. Thank you, Dr. Naveen, for this very important question. As she said, we have no margin between a pre-diabetic oral health problem and post-diabetic oral health problem. Unfortunately, we have no pre-diabetic oral health assessment for our client attending UNRWA health centers. Neither we have no DMF index or periodontal index for diabetic patient before diagnosed as diabetic. But according to the results, if you see that DMF index was statistically significant with the most variables, but with periodontal buckets and gingival bleeding, it was not statistically significant. This explains that problem. Because we have no pre-diabetic oral health assessment, this problem is occur. I mean, the result assured that diabetes is worsen the oral health problems of those patients, not the cause. They have already periodontal buckets, they have already gingival bleeding, but diabetes mellitus make the condition more worse. Thank you.
Thank you, Dr. Emad. Bram, would you like to respond to Dr. Naveen's question, please?
Yeah, thanks so much for those questions, Dr. Naveen, and wish we had spoken with you before we started. Would have made our lives easier, certainly. These are really good questions. The main to answer your first question about the small group, mainly actually just for reasons of budget. So we essentially fundraised to pay the salaries of these community health workers, and we started in 2018 with just 6. And we did an extensive training period with them, and got to the point where they work in pairs and can take about 40 patients per pair in a kind of average work week. And so the main barrier is really just I think this is a very, very cost-effective model based on the results kind of that we're seeing, but there's still quite a lot of input, and so we had to really start small with a pilot. Along the lines then, to answer your second question, we hadn't really been thinking about research up front. And so we didn't think about really a prospective study. After we had started, the impetus for this project came actually out of the fact that at the time there was no UNRWA clinic in Aida camp or Al-Azza camp. And now there is actually. This just opened in the last year. And the community was very interested in other methods of getting through the barriers that they were facing. And actually we presented a poster a couple of years ago at the Beirut LPHA conference on really what those barriers were. We did some focus groups. And so the community health worker project was a way of dealing with the barriers and dealing with the access issues of not having a locally contained UNRWA clinic. And so we wanted to really start right away. And only later did we think, hey, we should really look at what the impact of this is. And so we ended up doing a retrospective study with all the caveats that Asmaa mentioned. That said, our results were really robust. And I think, this sort of what we call social accompaniment of the community health workers has proven to be, really effective in terms of, motivating patients. We give them pill boxes, organizing their medicines, picking up their medicines for them if they run out, all sorts of different things just to all the basics so people can keep their diabetes on track.
Thank you very much, Bram. I think John Yudkin has a question. John, please go ahead.
Good morning, Bram, and congratulations to you and Dr. Asmaa for a really elegant study. 2 questions really. One very simple, that if it was only in the community health worker group, the delving into what the actual result of the hemoglobin A1C was, that was not done for the control, so you've got a bias there, which is going to be difficult to sort out. your plea for integrated health records is something I think Dr. Sater is on this conference, and so he will hear this, and I'm sure UNRWA will work on improving that. The second thing is simply, I'm not entirely clear, but you've outlined a little bit of it. What were the community health workers doing with the participants? Presumably diabetes was only part of it, sorting out their tablets, filling prescriptions. Were there interventions to do with lifestyle, smoking cessation, dietary interventions, for example, that could also have impacted the long-term health of people with diabetes, even if not their A1C? Thank you.
Great, thanks so much, John. And I'm not sure I totally grasped the first part of your comment. We did only end up using the A1C values that were in the UNRWA system. So we didn't use, even though we collected some point of care A1Cs and there were others that were available from the Ministry of Health and private clinics, but for the sake of the study, I'm not sure, but maybe I misunderstood your point. Dr. Sato was also an author on the paper, so he could probably weigh in as well. And in terms of the tasks, I started getting into a little bit, and there's really multiple components, and certainly diabetes isn't the only piece. There is work on smoking cessation, blood pressure. So a typical community health worker visit, they'll go into the patient's home. So these are home visits. It's a pair of community health workers, often sort of mixed gender pairs, and they'll check point of care finger glucose as well as blood pressure. And mainly just talk with patients in terms of how they're doing, checking with them about their diet, making recommendations about diet, checking in with how they're doing in terms of smoking cessation. And then it's a lot of, we have a sort of a trauma-informed mental health component of the program. And so the community health workers meet with a social worker weekly to sort of discuss some of their most difficult cases, because a lot of times they'll run into issues that are impacting people's diabetes that are much more social. For example, we had a patient who was, instead of buying his medications, was saving up all his money to give it to his son who is in prison, right? So dealing with these kind of factors and helping patients work through all the different barriers which might be far beyond education, in many cases are really these structural barriers of living under occupation, living in a refugee camp. And so it's hard to encompass all of it. Some of them, they will accompany patients to their visits. I mentioned organizing their medications, making sure they're taking their medications correctly, making sure if there are stockouts, we find alternate ways to get them medications. And I think that probably encompasses most of it. But a lot of it actually really has to do even just with, motivational interviewing, having, these patients know that there are people who care about them, these young people who come in and say, how are you doing? And making sure. And I think that it's just that checking in, once a week, every couple of weeks, depending how out of control their diabetes is, that really impacts people's motivation to get healthy.
Thank you very much, Bram.
Thanks a lot. I hadn't been clear about the multiple sources of the A1C test and the fact that you, in the end, used only the UNRWA ones. Thank you.
Yeah.
Thank you, John. Any final comments, questions from the presenters, participants? So if not, thank you very much for this very informative session. It raised many questions that needs to be thought about, and we'll be happy also to continue discussing this. Sorry for some internet-related interruptions that happened, but this is a fact of life here in Palestine. But we are resilient. We'll continue working. We'll continue doing research, and we'll continue improving the health of the Palestinians.